This is the operations report for Hipkins Hospital Orthopedic Surgery, but this will also be referred to as hip hop throughout this analysis. Hip hop's current operational surgical process is structured as follows. There are two surgical groups, A and B, each with two operating rooms or ORs, making a total of four ORs for this department. Each group can schedule up to 7 cases within the 10.5-hour workday. Upon arrival, patients are registered by one of the two registrars that are currently pooled. Then they move forward to receive preoperative preparations, as long as anesthesiology. And then finally, they undergo their procedure. Although this process appears to be straightforward, there are several underlying issues that disrupt the surgical operations. These include lack of standardized systems to differentiate complex, time consuming cases from routine procedures, insufficient support staff to assist with surgical and preoperative processes, limited adoption of updated medical technology, which could streamline workflows and reduce insufficiency. Currently, HipHops operates within a continuous surgery workflow. This is characterized by minimal downtime for surgical teams and limited structure in scheduling and patient assignments to specific ORs. This lack of structure contributes to insufficient and uneven disruption of cases. Current workflow statistics include with Track A, the average patient flow is 197.21 with 5 surgeries being completed. And then with track B, there's an average patient flow of 196.71 with about 4 surgeries being completed. Optimizing hip hop's surgical workflow can reduce daily cases throughput, enhance patient experience, and minimize disruption caused by non standardized systems and inadequate support staff. By implementing a structured scheduling system, expanding support roles, and adopting updated medical technologies, the facility can streamline and reduce flow times. Ultimately, through this analysis, we wanted to answer 4 lenses, and one of which was, does utilization matter? For this case, yes, utilization is a critical factor. It increases surgery support staff, increases the number of surgeons and anesthesiologists, assigns specific cases to OR groups, and this will aid in a better predictability. Does pooling matter? Pooling plays a critical role in the efficiency of the surgical operations. At this hospital, pooling ensures flexibility and resource optimization across all 4 operating rooms. First, registrars work as a pooled team to register patients for both OR groups A and B, reducing delays during the preoperative process and ensuring surgeries start on schedule. Then, environmental services also serve as pooling staff for this. The environmental services staff are pooled to clean and restock all 4 ORs. This approach minimizes downtime between surgeries, allowing the surgeons and anesthesiologists in each group to alternate seamlessly between their assigned rooms. By pooling resources, adaptability to fluctuating demands improves, bottlenecks are reduced, and throughput is maximized. This ensures progress towards the goal of completing 7 surgeries or up to 7 surgeries per day in each OR group while maintaining high quality of care. While pooling is important to make pooling effective, communication and coordination are key. With poor prioritization and adequate staffing, the system runs smoothly, benefiting both patients as well as staff. Does variance matter? Also serves as one of our 4 lenses for this analysis. Variance plays a critical role in the surgical process. In patient arrival, surgery durations, and OR turnover times can disrupt schedules, lower throughput, and cause delays. For example, inconsistent pre op readiness or unpredictable cleaning times can cascade into reduced surgical efficiencies. Implementing standardized protocols, buffer times, and data driven scheduling minimizes the impact of variance, ensuring more surgeries are completed on time while enhancing patient and staff experience. And finally, Does psychology matter? Which for me serves as a very important part. Patients, even in the healthcare setting, are essentially customers seeking a service. They expect professionalism, punctuality, and streamlined experiences, much like any service oriented industry, which is important. Delays in surgical procedures, although common due to various reasons, are often perceived negatively by patients. It is critical for the surgical team to manage time effectively and account for any potential delays to mitigate disappointment and maintain trust. An effective strategy to help with the psychological matter or wait time perception is to address patients' concern. This will address patients' concerns, particularly regarding their wait times, and this is to adopt the principle of under promising and over delivering. This is essential in all areas of healthcare. This approach involves setting realistic expectations and exceeding them when possible, creating a positive experience for patients. For example, how it could be used in a clinical setting, so specifically for surgery. If a 2-hour procedure is scheduled from 8 a.m. to around 10 a.m., and the next procedure typically starts at 10:30 a.m., it may be better to schedule the following procedure for 10:45 a.m., but bring the next patient back to pre-op slightly earlier, around 10:30 if the operating room is ready sooner. This builds in a buffering for unseen delays while ensuring the next patient feels prioritized. While patients wouldn't know when the scheduling opens, they do feel that if they are brought back at least 10, 5, even 15 minutes before their procedure, they feel prioritized and this improves patient experiences. Additionally, leveraging telehealth services can improve operational efficiencies and patient satisfaction. By pre-screening and completing the check-in process remotely, patients can bypass delays typically caused by in-person registration, and this strategy reduces the workload on registration staff while enhancing the overall patient experience by minimizing their time spent at the hospital. By implementing these approaches, healthcare providers can better manage patient expectations, improve satisfaction, and reduce perceived wait times, ultimately creating a more efficient and patient centered system. We'll now move into the use of optimization. So, while optimization and maximizing profit were not the primary focus for this analysis, it is beneficial to assess how proposed changes will impact the performance of the surgical department. So currently, the objective stands at $15,546.10. But with the optimal scenario that will be recommended, the projected um, best outcome serves around $27.4 million. And this highlights the significant financial potential that can be realized through the process improvements and efficiency resources utilized within the department. These are proposed new concepts that can be implemented within this surgical department. The current continuous surgical workflow creates an overwhelming environment for the surgical team specializing in hip and knee replacements. This differs significantly from other continuous workflows such as those in trauma or emergency departments where variability is a built-in expectation. Adopting a batch workflow would be more effective for this team. This method allows for a more organized approach by assessing patients with higher BMI levels to a single track, like track A or track B. But for this case, we'll use track A, while track B remains dedicated to patients with normal BMI ranges, and it can also serve as a pooling OR if needed, two pooling ORs if needed. That way, it can help if cases for those patients with normal BMIs finish sooner, they can also be pulled. Those patients with higher BMIs can be pulled into the track B OR. This structured system facilitates better resource allocations, reduced variability, and ensures a more predictable range of wait times and procedure durations. Additionally, leveraging updated technologies such as telehealth services for patient registration and preoperative screening can further enhance the process. By completing this step remotely, patients' wait times upon arrival at the facility can be minimized, improving the overall patient experiences and operational efficiency. So, with the patient wait times being reduced, this also helps reduce the bottleneck in this case, which is typically seen in the registration process and then as well with EVC cleaning. But for this case specifically, the EVC cleaning time is not taken into direct consideration as procedures end at the time that they stop and not when the room is fully cleaned. Finally, we'll move into our final recommendations. With the development of the new concepts in the surgical workflow and these final recommendations for staffing, this includes increasing the anesthesiologist to two for both tracks. So instead of one, it'll be two for each track. PAs will also be implemented and they'll serve as the support staff for both tracks, and this will help with the actual time to complete surgeries. And this will be in a pooling setting. So we'll pool two of the physician assistants that can be assigned during the surgeries. And then by having these additional PAs available, the surgical team can better manage patient care, assessing surgeries, and provide support where needed, which improves efficiency and reduces the strain on the primary surgery. And then we will also implement the telehealth services, and this will move the registration process to being in a more hybrid setting. The registration process will remain handled by the same number of registrars, but will include a hybrid approach. This means that patients can complete their registration and preoperative screening at home via telehealth services, and this reduces bottleneck at the hospital and erases the workload on the registrars, ensuring smoother patient flow when they arrive for surgery. And then finally, as previously stated, while EVC staff are crucial for the room turnover, their role in determining surgery duration is not included in the workflow timing. Surgeries will be considered complete at the moment the procedure ends, not when the room is clean. This ensures that surgical team is measured accurately without delays caused by room preparations. These staffing and procedures adjustments will help improve the overall efficiency of the surgical workflow, reduce downtime, and better manage the patient flow across all four ORs. By providing more resources during surgery and improving administrative processes, these changes can lead to higher capacity and improved patient satisfaction. Also, with the final recommendations, um, due to the stress that can be placed on staff aiming for 7 surgeries, this causes greater risk for the actual clinical team. But getting close to 7 leaves room for increased patient satisfaction, workflow safety, and reduced burnout. Therefore, these final recommendations serve as the best option to move forward for this operational approach. So, from the beginning, where we had the average surgeries that could be completed on both tracks being below 6, now with the final recommendations, the average patient flow is 135.97, with now 6 surgeries being able to get completed on track A. And then the average patient flow for track B is 140.36, with the surgeries that are able to get completed as 6 surgeries and opposed to 4. So, with that, these final recommendations and increased staffing, as well as pooling PAs for support staff, serves as the best option to move forward to ensure that we can get close to 6 surgeries completed on either tracks. Thank you.